Thank you so much for joining us. We are doing something new and exciting with this season of No Longer Silent. This time, we are going to insert voices of other national leaders to help expand the conversation. We hope you enjoy this new feature and let us know what you think in the comments.
Damage from the deep cuts to Medicaid in President Trump's spending bill could extend far beyond rural hospitals.
This is just one in a series of many, many cuts we're seeing across health agencies across the country.
Billions of dollars are on hold nationwide.
A local nonprofit organization says recent cuts under President Trump's new spending bill will force them to cancel one of their programs.
Federal officials are cutting more than $11 billion from health organizations across the nation.
No Longer Silent. Advocacy leaders unmuted. Thank you for joining another episode of No Longer Silent. In this episode, our topic of discussion is Power Where It Belongs, Community-Led Blueprints for an Accountable Healthcare System. Today, I am excited to have a dear friend of mine in the work of advocacy, Mr. Alan Balch. Thank you, Alan, for doing this. I really appreciate it. I know how busy your schedule is, and I know the demands on your time. So the fact that you're taking out this time today to just chat with me a little bit about things that are important to not just myself and Carrie's Touch, but the people that we get to serve. You are one human of many that truly, truly, truly has a heart for community, and you want to see people well, and you don't want to see people suffering. So that's what brings us to this conversation today. So thank you, and thank you.
Well, thank you.
Tell us a little bit about Alan Balch and the Patient Advocate Foundation and the National Patient Advocate Foundation.
Sure. So I have the privilege of being able to be part of the work of those organizations for 20 years as a board member, and the last 12 of that 20 as the CEO. And Patient Advocate Foundation is a safety net charity. So our goal is to provide assistance around access and affordability and other issues that patients may face as part of their journey. All the stuff that gets in the way of people being able to stay on therapy or complete therapy or access to the medications or treatments they need. We try to provide some different solutions to that. And then we do have a way that while we're helping people, we also want to learn with them about how do we make the healthcare system better for others. So we do that through health services research and a patient engagement and advocacy and education. We're helping patients directly through Patient Advocate Foundation. We're trying to change the healthcare system for the better. And our focus is on a very specific patient population. It is low and middle income individuals and communities that have the least access to and need the most help to get access to affordable, high quality care.
Wow. Good work, necessary work. And it's not easy work.
No, not at all. And I should add that we do that, a lot of that work in partnership with other organizations who have a similar mission and maybe reach, different patients in different ways, like Carrie's Touch.
So I'm going to dive right in because we are in 2025 and this work and its complexities were already a chore to manage and navigate. And now we find ourselves in 2025 when funding looks drastically different than it did in 2024. How are your organizations navigating this new space?
Well, I think it's a problem that ultimately impacts the patients we're all trying to help. We talk about the fragmented healthcare system, and we really don't have a system. We have a sick care system. The other part of that system is the safety net system, which is just as fragmented as the healthcare system itself, because of the choices we've made as a country, to have lots of different ways we pay for care and have access to care through different forms of insurance and things like that, and mostly a quasi-private public system, payers and hospitals, et cetera. The safety net becomes really critical to filling that gap and making sure that every patient has access to some basic level of care. And so what we're seeing is that safety net ecosystem being unraveled. So we're seeing, both our ability to provide assistance diminished, but also as we're seeing our own case management team, and what we call them case management, essentially they're resource navigators, they're seeing it's become a lot harder to find anything to help patients, particularly when it comes to things like housing and food. So just as a really specific example. It used to take our case managers on average about 20 contacts per case and about 10 days to solve just a basic resource need issue. It's now 40 contacts per case and takes almost 3 to 4 weeks to find something as it relates to like basic needs like food, housing, transportation.
Wow. I just have to sit with that for a second, because that is heavy. Just your last statement, going from 20 contacts per patient to 40 contacts in 10 days to possibly 3 weeks to try to find something.
More than 3 weeks. Yeah.
Yeah.
22 days, I think we're at.
Yeah. And we're all grabbing from the same resources, which is putting more pressure on, the relief that anybody can offer.
Regardless of how you feel like we should distribute healthcare as a resource, clinically or medically, we should all at least agree that we've got to have a unified approach to a safety net that makes sure that everybody has a reasonable level of access and affordability to that healthcare resource once we try to make it available in some way. Now, of course, you can lots of different ways to distribute healthcare as a resource, but you still have to have a safety net. And in those countries that have been successful, it's not because they're not just administering healthcare as a resource through government so everybody have access to it. They're actually also providing a robust safety net and a social security and a social welfare like Korea.
So, Alan, how do we fix it? What policies do we need to either write or support? And this is a tough question. Any policy question is a tough question, period. And in a system right now that seems to be imploding. And with government, the people that we have put in position to protect us aren't speaking up. How do we find hope? Where's hope?
I mean, I do think there's hope in that there's still a lot of heart there, and you still have churches and community-based organizations and food banks, and you still have, none of us are going away. Everybody is still committed to the mission, and there is a large group of organizations and people that understand this need, are committed to providing the need, and there's ebbs and flows to everything. So we're down now, but you can't keep us down for long. We'll get back on our feet. We're scrappy, right? I mean, that's always been, we've always been the afterthought in the healthcare system, right? Like, what about, and we got people healthcare. Now we got to get them help with all these other things too. So that's always been sort of an afterthought in the system. I do think the solution rests in, we got to build these things together, right? We got to integrate and incorporate and build, rather than, I think we focus too much on fixing the healthcare part of the system. I would prefer that we focus on creating and fixing the safety net part of the system, because if you don't have the latter, whatever construct you create for the former is still going to be inadequate for 30% of the country.
Right.
So if you create a safety net system that works, then you can build a healthcare system that works on top of it. So that's unfortunately right now we're just at a point where we're just playing, I think, defense is the best we can do right now.
The best that we can do, yeah.
Keep as much of it together as possible, and then pivot back when we can to, all right, let's build back better. That term is political.
Yeah, I was going to say, I don't think we need to build back better. I think we need to build new.
Different.
I won't even say back, but when we rebuild, we need to look at an entirely different model. And I think that, over your 20 years, involved in PAF and in PAF, you have seen this ebb and flow, maybe not to this extent, but you've definitely seen the ebb and flow. And what I know your organizations are really, really good at, that is powerful partnerships. And the power in those partnerships are going to be the foundation of this new way of providing safety nets. Help us understand how to build strategic and powerful partnerships that will help us in the rebuilding phase.
To me, it starts locally, right? Thinking about the safety net and what it looks like and access to it starting at a community level, right? Because that's where most healthcare is delivered. And so what is it that is done and can be done most effectively at the community level? And then you start to scale out from there. What can be done nationally, right? So that what are something you want everybody to have access to And it's more effective and efficient to have it more of a national pool, like like healthcare, like Medicaid, disability coverage, some of the financial assistance. And then you think about what you need on the local level really has to do more around trust and connection, making sure that every community needs it, has access to it, and is aware of it. And then you think about how to make sure that you have a national infrastructure as well, and then you connect the dots between those things. So it can't just be all community-based. It can't be all national. And we tend to parse those things out, say, well, it's all community, and then it's all national. And then, what we've tried to do, and I know others have as well, is like, well, what role can we play? And then what role can other organizations that are serving different communities at different scales, how can we work with them effectively and make sure they're connected to the resources we have? And then more importantly, looking at ourselves in the mirror and saying, how are we part of the problem? What is it about our processes and systems that make it more or less accessible to the patients who need it? And then making sure that we're doing everything we can as a service provider of safety net resources to make sure that we're not intentionally or unintentionally creating less access to certain communities because we don't have a portal that serves them, or you only get access through a hospital or through a pharmacy, or you only get access through a certain stakeholder group versus another. So those are the types of things when you have to. That's where it sort of forces you to think about how do you make sure that everyone who needs help has access to help.
We want to pause for a moment to thank our platinum partner, Amgen. Amgen has been a consistent partner who not just talks the talk, they fight hard to illuminate voices and experiences of diverse patients. We're truly thankful for such a beautiful partnership. But, none of this happens on a larger scale without policy. So what policies?
I will start by saying I think it helps to take a broader view of policy. So if you think about policies, the ability to wield influence and change at an institutional level. And so policy is created at not just a legislative level, state, locally, federally, but also step therapy is a policy created by insurance companies. Pathways are a policy created by hospitals and also insurance companies. Patient-reported outcomes. You go down the list. There's a lot of things that are decisions or choices that determine behavior in a system that are decided by somebody with power. So there's a lot of ability to influence policy across multiple stakeholders at the clinician level, at the professional society level, at a community level, at a payer level. So I think if you take a broader view of policy, you can think about different solutions that don't necessarily require a ballot. So that's sort of rule number one is, look for those places to partner and create policy or solutions that maybe don't necessarily require legislation or, direct democracy. Not that, there's certainly, it's great if you could do it that way, but there's a lot of inherent friction in the system intentionally designed for federal or state or any kind of policy. So it takes a long time and requires a ton of consensus to even get something over the finish line and then you have to implement it. So I say all that to say, when you think about like utilization management, step theory is an arrow in the utilization management, so to speak. So if you kind of lump utilization management together in different tools that that payers have to try to, and if you kind of put yourself in their shoes, they're trying to make sure that patients don't get access to inappropriate care, or that they don't get access to too expensive care when there may be something that's cheaper or just as effective that they could try first. So there is some, rationale to why they implement these policies. I think inherently the challenge becomes, especially in an era where the science is all becoming more personalized, not just medically, but as in the delivery of care. Everybody talks about personalized, and that's what patients want. They want the most personalized care possible. It means looking at who you are as an individual and thinking about your care and treatment through the lens of who you are and what you need as a person. So that would extend in our minds, that's sort of whole person care. That extends to thinking about their housing, their food, their transportation in the context of, but separate from their treatment, right? Because the things come together at a certain intersection where if you don't do that, kind of goes back to the earlier point that these two things are interrelated, whether we want to admit them or not. And the safety is there largely to address those non-clinical things. And of course, we're not even doing as good as we should be on the clinical part of care. But I think ultimately, if you look like where the future of medicine is heading, both from a medical and a non-medical perspective, it's about making sure the right patient gets the right care at the right time. The right care I'm using very explicitly because it's not just about treatment, it's about care and whole person care. So if that's the mandate, everybody agrees to it. Everybody says we agree to that. step therapy is the wrong solution. It doesn't help patients get to the right care at the right time. It does prevent, in some cases, patients getting the wrong care or too expensive care. But unfortunately, too often it leads to or can lead to patients getting the wrong care first. But I do think there are some solutions that we can create in the healthcare system that would avoid or mitigate the need for step therapy.
First and foremost, I was so glad that you came around the corner and talked about some of the problems with step therapy, because after this call, I was going to call you and say, Alan, you cannot believe that step therapy is the way. It's not the way.
No.
But
I'm just trying to, explain why it exists.
No, yes, that was beautiful. That's why I said I'm glad you came all the way around in your explanation. Let's bring another voice into this conversation. So why is it so important for community-based organizations to understand policy and political strategies?
We have to acknowledge, whether we like it or not, that our economy is capitalistic. It's really survival of the fittest. The politics comes into who shapes the policy, and then it also comes into who benefits or doesn't benefit from the policy. Whether it's a healthcare issue that Carrie's Touch may be dealing with, or brick and mortar issues like what physical location can Carrie's Touch operate in, right? All of that is decided by government in some way, even if it's private sector. People realize, the private sector is impacted by government. Government is a huge, sometimes visible or less visible influence in all of these things.
You'll come back and make sure you check out Jovan's full episode. I would be remiss if I didn't say that many of the people that suffer are people, like you have said before, they're low income, they're Black and brown people, and that's part of the explanation of the high mortality rates across disease states, in Black and brown people. It's not the only reason, but it is, a factor when there's already trust issues between the community and medical professionals. And a lot of what you talk about, in order to build that trust, we've got to, and I don't want to use this word, but it is the right word. We've got to diversify what the physicians look like. There will be many people who, because of their lived experiences, they will be able to care for the patients in the way that you're talking about. But when you have lived a life of privilege, and you have never had these experiences, and you've not gone into the communities, and you only go through book knowledge, and even the stuff that you learned. My son's a physician, and he is in residency, and what the attending physicians say to him are things like, and when you get out of residency, you're going to do all of this differently, And so I'm like, what's the point? What's the point?
Well, I think that speaks to they're trying to standardize the experience, and we're going to train you all the same. But the reality is, when you get into the real world, just like when we test a drug in a clinical trial environment and then put it into the real world market, it behaves differently. We don't know enough about it. And so same thing here. It's this idea of we're going to standardize the process. We're going to train you to a certain standard in textbooks and things that are mostly designed by white men over the years. And now when you get into the real world, it's going to be different, because you're going to have to practice real world medicine as opposed to textbook medicine, which is a different thing.
So, Alan, there's so much more that I want to ask you, but as we are winding down our time, what I want to ask you now is there something that I have not mentioned that you would like stated in this conversation?
Just don't think we can ever lose sight of the fact that we have inequitable access to care in this country. We can use whatever words and terminology we want to describe it. It's not new. It's always been there. And that inequitable access is visible by race and ethnicity, by geography, by age, by disease. There's multiple layers and levels to where and how and why that exists. And we have to address that. We can't sit back and just say, well, good luck. You've got insurance. Yeah, that's all we need to do, because there's not just from a moral perspective, just from multiple different lenses, economically, social, whatever lens you want to look through, there's a case to be made for why we should try to create equitable access to anyone who needs it. Starting with insurance coverage, because that's the basics. But then even in the presence of insurance, there are other issues that get in the way of people being able to get equal access to the efficacy and safety they deserve in the investments we've made in health technology over the years, and that people have better access to theoretically in this country than anywhere else, but not if they can't afford the transportation to get there or the management, the food they need to manage the side effects. I mean, the list goes on and on. So we have to think about whole person care, and that's not just about treatment. It's about thinking about the needs of the individual that have to be met to some degree in order for them to be able to maintain access and adherence to their treatment. And call it whatever you want. That's not going away. And it's a moral imperative. It's an economic imperative. It's a social imperative. We cannot lose sight of that. And we cannot let it become a dirty word. Right. That trying to address those inequities in the various populations and communities they exist is something we have, and a challenge we have to meet.
Wow.
Sorry, that was a little long-winded.
No, you weren't long-winded at all. You were perfect, and I love your passion. I love working with you because of your passion, and because you're a person that says, I am going to take my personhood and my privilege as a white male here in America, and I am going to use it to help my fellow Americans. That's truly patriotic. If we want to talk about patriotism in this country, that's what it should look like, right? That we stay up long nights finding solutions and resources to support the least of these. One final question in this space is just, what's your closing thought for this conversation?
As much as the healthcare system is important, and we all talk about it and we focus so much attention on it, I would plead that we focus more of our attention on the safety net and building that truly if we want to build a system of something in this country, that's what we should start with, building a safety net system that includes local, regional, national, even international, but let's start with our own, we're talking U.S. healthcare. So that's the system we should endeavor to build. And if we do that successfully, we can more successfully build whatever healthcare system or lack of a system on top of it. But we should focus on building that safety net system, and not to the exclusion of the healthcare system, but that to me is sort of the critical calling. Every stakeholder benefits from that, whether it's the hospitals, the clinics, the community-based organizations, the nonprofits. The way to create more equitable access to the system starts with having a robust safety net that catches as many people as possible from falling through the cracks.
It makes 1,000% sense. The feasibility of it, since we have a sick care system instead of a healthcare system, is where the challenge comes from. And if all of this gets bottlenecked and stopped in the implementation process of it, I feel like we find ourselves spinning our wheels, so to speak. And it's like, okay, we'll lose 30% of the population, but we save 70% and we're good with 70%, and we're okay with losing 30% of the population. So I like your idea. I think your idea makes sense. I just struggle with the feasibility of it, with working with what the systems that we currently have in place. And with them feeling like they're going to hell in a handbasket as we speak, with, Congress gutting.
We shouldn't be having a conversation about cutting Medicaid, right?
We shouldn't be having that conversation.
That should be one of broad bipartisan agreement that if we're going to create different levels of affordability for insurance, we have to have an outlet for the, if we're not going to provide it to everybody, through some government fiat, then we have to figure out how to make it accessible to those who may not be able to afford it otherwise, because you're just creating tiers of different classes of people with different access to the most basic need that people have, which is healthcare. So there's nothing communist about trying to make sure that everybody can afford insurance if that's the car you need to even get on the healthcare freeway. So maybe that's too political, but
Oh, it's not too. It's not too political.
There's a few out there that are standing up for that.
There's a few, and we're just going to pray to God that there will be a few more. We'll pray for more moments like his name just slipped my mind, but a few years ago when they were voting for the Affordable Care Act, he was the deciding vote.
Oh yeah. John McCain.
John McCain. Yes. Thank you, Senator. Well, but he did the right thing at the right time. So that's what I'm praying for. Senators, good or bad, to do the right thing at the right time. We always try to end on a light note because
a light note. Okay.
Yeah, this is light. What's your favorite flavor? Chocolate, vanilla, or strawberry?
Oh, double chocolate.
Double chocolate. Wonderful.
Yep. All day, every day.
Thank you so much for listening to No Longer Silent Season 2, Advocacy Leaders Unmuted. Special thank you to our platinum sponsor, Amgen. Thank you for being such a long-time partner and friend in this advocacy space. And none of this would be made possible without our dynamic tribe here at Carrie's Touch. Thank you, Josh. Thank you, Angelica. We will see you next time on the next episode of No Longer Silent.